So my name's Dr. Jeff Gerber. I'm a family doctor from Denver, Colorado. And I use food as medicine to treat and prevent chronic disease. What a novel idea. So today I'd like to talk to you about diabetes, cardiovascular disease, and navigating through the muddy waters when it comes to cardiovascular risk assessment. So I'd like to begin by introducing you to a couple of people. So in the middle, of course, that's me. And to the right of the screen is my engineering problem-solving friend, Ivor Cummins, who's here in the audience today. And he flew all the way from Ireland just to make sure that I deliver this information accurately. Thank you, Ivor. And so last summer, he convinced us to fly to Chicago to visit this spry spry-looking physician, Dr. Joseph Kraft, who, by the way, says hello. He couldn't be here today. But Dr. Joseph Kraft spent his career as a pathologist studying insulin metabolism and looking for root cause. And he was also finding that there was a strong connection between insulin metabolism, insulin problems, and cardiovascular disease. And he found that there was such a strong link that he said that those with cardiovascular disease not identified with diabetes are simply undiagnosed. And I'd like to explain to you why he said that. So Dr. Kraft was the chief of the Department of Pathology and Nuclear Medicine for over 35 years at St. Joseph Hospital in Chicago. And during that career, he created what is called the insulin assay. And he actually did this test in over 16,000 subjects. That's astounding. He also did over 3,000 autopsies. Again, he was looking at root cause. He collaborated with others, trying to find this link between insulin and cardiovascular disease. Now, he was also well published in the medical journals. But it was when he retired that he wrote a book. And by the way, he turned 95 when Ivor and I interviewed him last year. So he wrote this book, and this book really details his life's work. And what I'd like to do is talk to you about the book. The book is amazing, especially if you're a healthcare professional. It reads more like a medical peer-reviewed journal article, but it's just every healthcare professional should read this book. So we're going to talk about the insulin assay. And so what Dr. Kraft set out to do was to prove that standard methods of diagnosing diabetes and prediabetes were inferior, and that standard method was measuring blood sugar. Okay? And the standard method is either during a fasting state. And unfortunately, for years, we used that as the screening tool for prediabetes and diabetes. It's a terrible tool. That was easy to prove that it was not so good. The problem with using it as a screening tool is that you never went on and did the 2-hour glucose tolerance test. In fact, that's really fallen out of vogue, so that test is giving a glucose challenge. Today, we use 75 grams. Dr. Kraft mostly used 100 grams. It's not a bad test. And then he also showed that hemoglobin A1C, as we traditionally measured it, wasn't so good. So we used to say, if your A1C is over 7, you're diabetic. Now, at least we're dropping what is considered normal. So he actually showed back in 1975 that these methods were indeed inferior, but I'm going to just show you some of the details. So the insulin assay. This was based on radioimmunoassay, radioisotope studies that were really being developed in the 1950s and the 1960s. And what it was doing was measuring very low concentrations of substances. In this case, we're measuring insulin in microunits. And what he did, although it was 16,000 subjects for the book, it was over 14,000 subjects. He did insulin assays. And it's similar to a glucose challenge. In this case, he gave 100 grams of glucose in most of the individuals. But he measured not only glucose, but insulin over a 5-hour period of time with intervals in between. And when he looked at the data, he found that it clustered into 5 distinct patterns. Now, there was pattern 1 that was called normal, and then there was pattern 5 that was called low insulin. Now, mind you, nobody really knew what normals were. And he really, again, was creating this gold standard test to define what insulin in the blood should measure. So we have those 2 patterns, and then he measured the 3 patterns of hyperinsulinemia. He also called it diabetes in situ. And what he was doing was, again, finding a new method to define diabetes and prediabetes, and even redefining diabetes at its earliest stage. So I'd like to go through those patterns, and we really have to thank Ivor for these absolutely beautiful graphs that I couldn't do on my own. So this is pattern 1. So pattern 1 was described as normal, and you can see that the fasting insulin is low, and throughout the test it doesn't spike over 60 microunits. On the next slide, you can see in the blue is again the pattern 1. And now what we've superimposed are these 3 patterns of hyperinsulinemia, or diabetes in situ. And so you can see that pattern 2 and 3 start out with a low insulin. That's the yellow and the orange. And they differ in that the pattern 2 in the yellow peaks early, and pattern 3 peaks late. But again, it's quite high, the insulin levels. And then pattern 4 is different in that the fasting insulin is high. And then insulin spikes, just goes incredibly high. And so what you can see is that this is a disease of beta cell hypertrophy that produces insulin, and it is indeed a disease of insulin excess. So this is what I like to call pesky pattern 5. And we have to think about this one for a minute. So what state do we see low insulin? And clearly we see low insulin in type 1 diabetics that aren't producing insulin. Okay, we also see this pattern in what we call burnout type 2 diabetics, where their beta cell function doesn't work anymore. Now there's 2 other patterns, or there's 2 other situations where we see this low insulin. The first is a low carb diet, and the second when you're intermittently fasting. Now what Dr. Kraft showed back in 1975 is that you take patients on a low carb diet and you actually load them with carbs for a period before you do this glucose challenge. And this pattern 5 perhaps reverts to a normal pattern. Maybe not a normal pattern, okay? But what is fascinating about this is that some people say, well, on a low-carb diet, you have an insulin deficiency as a result. In fact, it's also been referred to as physiologic insulin resistance. But there's no deficiency. It's just a normal physiologic adaptation to not eating carbs. Now, we've been doing glucose tolerance tests for over 15, 16 years in our office. And this is just an interesting observation because we have patients on low-carb diets and they want to know, well, should we do the Kraft testing or not? And it depends. But we find it's fascinating. And just by the way, I've done over 2,000 glucose tolerance tests. Recently doing 2-hour insulins. We've been doing fasting insulins for a while. But it was just a matter of getting people down to the lab and so forth. But I'm not even close to what Dr. Kraft did. It's quite impressive. So the other thing that Dr. Kraft said is that hyperinsulinemia occurs before hyperglycemia. And so how can we demonstrate this? So this data comes from Catherine Crofts, who's in Auckland. And she is working on her doctorate. In fact, she's a candidate for doctorate. And this is actually unpublished data. And what she did was she actually took Kraft's data and reanalyzed it. And what she shows is actually these are the 3 patterns of hyperinsulinemia, although she's showing 4 patterns because she broke down pattern 2 into 2A and 2B. But in every case, if you look at the insulin level, they all failed the insulin assay. These were actually adult patients from Dr. Kraft. So they had high insulin levels across all patterns, and yet their blood sugars were normal based on standard methods. So indeed, this demonstrates that hyperinsulinemia does occur before hyperglycemia. So I still wasn't convinced that measuring glucose was such a bad thing. So what I did was I went and really reanalyzed Kraft's data. And I came up with something called a confusion matrix. Now this is the part where your eyes are going to glaze over. But the confusion matrix is something that healthcare professionals really use all the time, although they can get confused by it frequently. And so what we're doing is comparing one method to another. And so in this case, on the top, we're comparing hyperinsulinemia, which is the Kraft test, which is the gold standard test, to standard methods, which is hyperglycemia. And you can see on the right of the slide that the positive and negative predictive value really tells the individual getting the test what their likelihood of having a disease, in this case diabetes or prediabetes, given a positive or negative test result. And on the bottom we see sensitivity and specificity. And that tells the investigator or the clinician how accurate or valid their methods are. And what you can see here is that based on a positive predictive value of 97% and a specificity of 92%, if you do a standard glucose testing on a patient, including glucose tolerance test, you know there's a problem. And you don't even actually have to do the Kraft assay. Okay? But the problem is if you get a normal glucose result. And to look at that, you have to see that the negative predictive value is very low at 28%, and the sensitivity is only 52%. I hope I've confused everyone. Good. So that was the point, kind of. But to understand it better, let's go to the next slide. So you do standard methods, and you come back euglycemic, your blood sugar is normal. So the individual at this point can be 28% certain that they're okay. But on the flip side, there's 72% of them that aren't okay. That's easy to understand. So remember I said if you do have an abnormal glucose response, you're pretty good. So the test method can pick up 52% of the population based on sensitivity, but the test method is going to miss 48% of the people. So having a normal measurement of glucose isn't reassuring at all. That's what Kraft showed. The next question is, could Dr. Kraft's work predict population risk? And it really wasn't designed to do that. It was clearly just to show a better method. But what you can do is apply it to populations. And so in this case, we're going to apply it to a recent NHANES study that came out last year that predicted that there's a staggering 52% of the US population that have diabetes and prediabetes. And what was really good about the study is they took the 2011 and 2012 cohort, and it was almost 3,000 patients that represented the US population. And so what they did was to do glucose and proper glucose tolerance tests on these patients. And I think that's an accurate number, 52%. So they actually did proper testing of standard methods. Now just imagine if they had done a Kraft assay on all these patients. I'm going to guess and say that probably over 75% of them had a problem. And people are still complaining about this study that, oh, that 52% is outrageous. That's not true. Yeah, it probably is. So now I want to switch gears and talk about cardiovascular disease. and ask the question first, is there a diabetes paradox? Some people say that despite seeing more diabetes and obesity, we're actually seeing less heart disease. So we have to think about that for a minute. And what's absolutely true is that since 1995, modern medicine, I believe, has done a great job addressing morbidity and mortality associated with cardiovascular disease. That is specifically treating the complications. And I think smoking cessation has a lot to do with that as well. But you can't confuse or conflate morbidity and mortality with incidence and prevalence. So those are measurements of the occurrence of disease. And that's really hard to look at. And that's the whole point of this talk today. So how can we look at incidence and prevalence? And one of the ways you can do it is to look for subclinical disease, doing cardiovascular imaging, such as calcium scores, perhaps the CIMT that Dr. Halberg was talking about, and even autopsy studies. And so when you look at these studies, you actually can see that with more obesity and more diabetes, there's more heart disease. So as I see it, there is no diabetes paradox. So what did Dr. Kraft have to say about cardiovascular disease? So he noted that it was a metabolic disease. And the metabolic defect, of course, was hyperinsulinemia. And he said, look, if you don't pick up hyperinsulinemia or diabetes early on, you're going to be missing cardiovascular disease. And then in 1988, Jerry Raven comes along, and he makes headlines for his work, what he called Syndrome X, what we now call metabolic syndrome. And guess what? He too noted that atherosclerosis, or cardiovascular disease, was again a metabolic disease. Now, the metabolic defect that he focuses on was insulin resistance. Insulin resistance and hyperinsulinemia are very closely related. The insulin resistance might be something that occurs downstream, perhaps. But he noted that the components of insulin resistance included glucose intolerance, hyperinsulinemia, this atherogenic dyslipidemia, where he said, okay, it may not necessarily have to do with the concentration of cholesterol, but rather the quality of cholesterol. And then, of course, hypertension. Now, when I first heard about this in the 1990s, I thought that this was just astounding, that there was this connection and a metabolic explanation for cardiovascular disease. And even today, most mainstream doctors know about the work of Dr. Raven. But it still didn't gather much traction, and I found that curious. Why not? And really, in my vision, metabolic syndrome was really a condition that was treated via lifestyle. There are some medicines, but it was a lifestyle illness. And it's unfortunate that Dr. Raven and Dr. Kraft didn't really dive into the nutritional aspect of it. And so it was just a lost opportunity. So frustrating. But also, it's interesting that these guys never collaborated. Maybe that's the way it worked back then. But anyway, since the time of Kraft and Raven, you look at the medical literature, and there is this strong link between diabetes and cardiovascular disease. But when it comes to clinical medicine, not so fast. So we have diabetics on the one side that have no idea that they have cardiovascular disease. And on the other side, we have heart patients that are clueless that they're diabetic. So why is there this disconnect? I'd like to welcome you to the Framingham Distraction. Yes, that's Framingham, Massachusetts. And so this is where the original cardiovascular risk assessment occurred back in the 1940s. In fact, they're now working on third generation looking at this. And it is fascinating. But since the time of Framingham, they now have come up with different risk assessment. And the risk factors, again, here are lipids, cholesterol, smoking, hypertension, and diabetes. And so over the years now, the risk assessment tools have have changed. They've come out with risk calculators. But the main focus is cholesterol, and really cholesterol only. And when you look at the newer risk assessments tools, I mean, that's just the theme. It's cholesterol. And therein lies the problem. They've got us thinking just about cholesterol. Diabetes risk is in there, but it's absolutely buried. And I can tell you in clinical medicine, this is this disconnect. It's absolutely crazy. We see so many patients coming into our office, cardiac patients. We do our standard, we do our testing. They're diabetic, okay? And then, we diagnose people with hyperinsulinism or prediabetes, and we do calcium scores and we find risk. So, I mean, the message is that it shouldn't be disconnected like this. It's absolutely connected. So what is it about this lipid-lowering therapy? So, the mainstream or the medical doctrine tells us that high cholesterol is bad and it requires remedy. Okay, well, what are the mechanisms? Well, they talk about concentration gradients in the blood. Okay. They talk about inflammation lately with the use of statins. Maybe not so bad, but to me, the mechanism really remains elusive. So those are the experiments, okay? And the best experiment that they have is 2008, the Jupiter trial. So this is the trial that they tried to tell us that we need to put statins in the water for primary prevention. And if you believe that information, the best that we could come up with is that if you give a statin to a patient who's healthy, it will only reduce their risk by 1% over 5 years. So it's not very impressive, and that's the best that they have. Although we do use statins in certain patients, I don't think we're throwing it away completely. So let's further debunk this lipid hypothesis. And these are really associational or observational studies. So you can't prove anything, but it just is thought-provoking. And so we have the Get With the Guidelines in 2009. And in that study, they took a group of patients that were hospitalized with heart attacks. And they looked at their cholesterol profiles. And 75% of them were at goal. And yet there they were having heart attacks. So again, why were they in the hospital if they were at goal? It doesn't prove it. It just makes you think about it. The second is last year they came up with another study towards a paradigm shift in cholesterol. And that study showed that elderly people who had higher cholesterol live longer. We got a good response from that one here. So it's just thought-provoking. And so now let's look at the mechanisms for hyperinsulin or insulin metabolism. And they're really solid, they're irrefuted. In fact, this slide comes from the American Heart Association. And the mechanism is that of inflammation and oxidative stress, and also advanced glycation end products. And so what this is doing is having an effect on the epithelial cells on the body. And it's basically an inflammatory disease all the way through. And the idea is that you want to address inflammation and oxidative stress. Now there's other theories such as neovascularization or infection, but ultimately they're all inflammatory diseases. And then when you look at the experiments, what we can say here is that, again, with more diabetes, you see more cardiovascular disease. And there's really experiments that actually demonstrate that. In fact, if you go back to the studies looking at cholesterol as a risk factor, if you dig deep, you can see that the problem was insulin all along. But they're not going to listen to me. We really need to get the researchers like Dr. Halberg out there to prove these things. So if you have to make a choice, is it going to be Framingham or is it going to be diabetes risk as an independent marker? And so we can look at these muddy Framingham risk factors. And when we look at it, we really want to look at middle risk people. So, you know, if we have a high risk individual, let's say they're a smoker, you know, they're overweight, they're diabetic, they're inactive, everyone knows that they're at risk for cardiovascular disease. But the middle risk people are the ones that maybe are a little overweight, they don't have high blood pressure, their cholesterol's a little bit borderline. You know, that's middle risk. And if you run them through that risk calculator, they only have a 2 to 3-fold risk compared to baseline. But then if you run them through just a diabetes assessment, they can be up to 6 to 8 times at risk for cardiovascular disease. And then to consider that Dr. Kraft, again, is saying that we're missing all these people. It just makes more sense to look at diabetes risk. So, bottom line, it's the insulin, stupid. And I'm talking about the good doctor. And it's just to focus on the inflammatory component. Focus on insulin, insulin resistance. To note that atherosclerosis is a symptom of diabetes. And that many are at risk and they're not identified. And that it's really not a disease or a condition or a syndrome perhaps that is treated pharmacologically. I mean, it's really a lifestyle illness. And so what is the lifestyle recommendation that we're going to give these people to prevent the arteries from getting clogged? And I don't believe that, you know, clogging is a mechanism, it's inflammation. But this is just a beautiful graphic that I think represents junk food. And so we could just say cut out the junk, but you know, that's old. And we really have to give some more detail as to what we're trying to say. And we're trying to keep it simple. Simple is good. And so we think about what are the macronutrients that drive insulin. And so obviously it's carbohydrate first, it's protein next, and then it's fat last. And maybe the advice should be based on that simple understanding. So this is what we tell our patients. Low carb is best. How can that be bad advice? Okay? You're going to cut out especially grains and sugars. Okay? We're going to eat real food. We're going to cut out processed food, including industrial vegetable oils, and eat more natural fats. And for Dr. Rangan, I think we're going to add fiber in here. Okay? If the first 2 points are working, guess what? You eat less. Okay? But I think it's important for people to know that eating less is part of this. Okay? But it happens naturally. Okay? Movement and activity, not that that will make you lose weight, but there's so many other benefits, both cardiovascular, including improving blood sugars. Of course, smoking cessation, sleep and happiness. You can't do anything. You can't help your patient unless those 2 things occur. So clinical assessment. Healthcare professionals need to think early on about insulin and metabolic disease and insulin resistance, hyperinsulinemia, okay, to realize that a fasting blood sugar, maybe HbA1c, are not so good as a fasting tool. In our office, we've tried to make the glucose tolerance test better by doing the 2-hour glucose tolerance test with a 1-hour measurement. Now, doing the Kraft insulin assay, practically it's really difficult to do. Now, there's a lab in California that actually you can do a home test, which is kind of interesting. We've had patients come in. But Catherine Croft, after analyzing the data, came up with a simple method that will shortly be published, but that is to do an insulin at 2 hours only. And the cutoff is under 30 microunits, you're probably okay. Between 30 and 40, it's kind of the gray zone, so you kind of want to look at the big picture, and over 40, you definitely have a problem. So you look at inflammatory markers, lipid ratios, so it gives you the whole picture. And this is really how we do it in our office. And you know, I'm not surprised anymore because, you know, so many people have a problem. And how can you say, well, the low-carb diet's not good? Everybody agrees that if you have an insulin problem or you are insulin resistant, yeah, low carb, high fat's good. Well, okay, it might be that 52% of the population or more have a problem. So that should be the default diet, right? Okay. So I'm going to shift gears, almost done. We're going to talk about cardiovascular imaging. And so if you want a tool that trumps Framingham, this is it right here. And you can mention to Dr. Halberg again. I think the CMIT, it's okay, but the calcium score is absolutely gold. And what we're trying to do is to have a tool that is relatively inexpensive and non-invasive. And so I'm going to show you two calcium scores here. These are two different people. And so the person on the right has a high calcium score. So what this test is using is a high-speed CAT scan machine, a little bit of radiation, and because the heart's beating, we're trying to look at these tiny coronary arteries, and they take little sections in there looking for calcium. So normally you don't have any calcium. So as atherosclerosis develops, first it's soft plaque, and then it becomes calcified. And we can start to measure that. And so on the individual on the right, it looks like somebody is not very muscular. I'm going to guess it's an elderly person, but that person has a calcium score probably in the thousands. And then on the left is my calcium score from last year. Maybe this is why I'm partial to it, but I have no calcium. Okay, so I have a perfect calcium score of 0. Okay, now this testing has been done in literally tens of thousands of people. It's quantifiable. It's reproducible. Okay, so my 10-year risk of having a cardiovascular event, in fact, there's another data that says my 15-year risk of dying from a heart event is less than 1%. So I just think it's very useful. And then, this is just one slice, but if you look through all the slices, you can see that in my study, throughout, there's no calcium. And I'm on a low-carb, high-fat diet for 15 years. I'm eating whole foods. Okay, and I have diabetes in my family. So am I genetically blessed? Your decision. So this is the calcium score where they can just grade it, and the higher it is, the greater your risk. Now, progression is a problem, okay? And what this shows on the right is that if you have a high calcium score and it progresses greater than 15% a year, for instance, on the first one here, with a calcium score over 1,000, the mortality from cardiovascular event drops to almost 50% over 3 years. It's scary, okay? But on the flip side, if you stabilize your calcium, your risk drops to almost nothing. So the message is stabilize your calcium score. That is powerful. And if it's progressing, you've got a problem and you got to do something about it. So I hope that the muddy waters are clearing when it comes to cardiovascular risk assessment. And so cardiovascular imaging is important, but when your doctor or you want to grab for that Framingham risk calculator, they'd be better off looking at insulin or insulin metabolism, because what's most important is that diabetes is a vascular disease. Thanks for your time.